Welcome to this Radonc Smart Review GI Cancer Series session. We are really excited today to unpack a critical and, frankly, rapidly evolving area of GI oncology.
Absolutely. Today we're diving deep into gastric cancer part 2. This is, a direct continuation from where we left off talking about resectable disease, high-quality D2 surgery, and perioperative chemo like FLOT.
Yeah.
And the big question for us as radiation oncologists, it always comes back to this. What exactly is the role of radiation therapy now in this landscape?
It's a huge question, and one you'll face all the time. So our mission for you today, well, it's a few things. We want to really unpack those pivotal trials that shaped and honestly reshaped adjuvant chemoradiation. Then we'll explore the targeted therapy side, especially HER2-positive disease, which is so important now. And finally, put it all together, a practical treatment planning session, something you can actually use.
Sounds good. But before we even get to the trials, maybe we should just quickly touch on pathology and biomarkers again, because they're just so fundamental for treatment selection now.
Oh, definitely. You can't really talk about modern treatment without them. The specifics of the tumor biology, I mean, they can completely change the plan, right?
Exactly. And one of the absolute must-dos, especially for advanced disease, is testing for HER2 overexpression. It's mandatory in all metastatic gastric adenocarcinomas.
Yeah.
Not optional.
Mandatory. Got it. That's a critical point. It dictates therapy.
Right. And it's not like it's found everywhere equally. You see it more often in intestinal-type adenocarcinomas. And it's really significant in tumors right at the GEJ, the gastroesophageal junction.
GEJ, yeah.
It can be present in like up to a third of cases, 33%. Knowing that helps you anticipate who might need those specific targeted agents.
Okay, so that GEJ prevalence is a key point. Good to remember. All right, let's get into the adjuvant radiation story. It's got quite a history.
It really does. Lots of data, lots of reinterpretation as things changed. But the foundational trial, the one that really put postoperative chemoradiation on the map, and definitely on your boards, is Intergroup 0116.
Yes, the McDonald trial. Can't avoid that one.
Nope. Published back in 2001, New England Journal. It randomized patients, resected stage 1B through 4 M0 gastric, or GEJ adeno, to either just observation or post-operative chemoradiation.
And the chemo-RT regimen?
It was 45 gray in 25 fractions, pretty standard, and it was given with concurrent and sort of sandwiched 5-FU and leucovorin in.
Okay. And the results were, well, they were pretty striking at the time.
Oh, absolutely unequivocal. Adjuvant chemoradiation improved median overall survival, went from 27 months with just observation up to 36 months.
Wow, 9 months.
Yeah, and the 3-year overall survival jumped too, from 41% to 50%. Those were big numbers then.
Really impactful. But there's always a but with these older trials, isn't there? Especially when we look back with modern eyes.
Exactly. And here's the really interesting part, probably the most important thing to remember about 0116 for your boards today. The surgery.
The surgical quality.
By today's standards, it was suboptimal. Massively suboptimal, actually. Only 10%, just 1 in 10 patients, got a proper D2 lymph node dissection.
Only 10%. That's low.
It's incredibly low. And more than half didn't even get what we'd consider an adequate D1 dissection. So what happened?
High locoregional failure in the surgery arm?
Bingo. A very high rate. And the adjuvant radiation basically cleaned up that residual regional disease left behind by the less extensive surgery.
So the benefit was largely tied to compensating for inadequate surgery.
Precisely. That's the critical nuance.
Yeah.
The powerful results of 0116. They primarily apply if you've had incomplete surgical staging, a less than D2 lymphadenectomy. You have to grasp that for clinical decisions today.
Okay. That context is absolutely key. So that brings us to the modern era. What happens when you do have a proper D2 dissection? The standard now. Do you still need adjuvant RT?
That's the million-dollar question. And 2 key trials help us answer it.
Let's start with the critics trial, the Dutch study.
Right, critics. They compared 2 pretty strong strategies. One was perioperative chemo, like the MAGIC regimen. The other was preoperative chemo, followed by postoperative chemoradiation. So chemo, then surgery, then chemo versus chemo, then surgery, then chemo ARC.
Okay, and what did they find comparing those two?
No difference. Basically, no difference in 5-year overall survival. Both arms were around 41%.
41% for both. So adding the radiation postoperatively didn't add a survival benefit if you already gave effective chemo up front.
Exactly. It was a major blow to the routine use of adjuvant radiation after good chemo and good surgery. It strongly suggested the systemic therapy was doing the job.
Okay. And the other key trial was ARTIST from Korea.
Yes, the ARTIST trial. This one took patients who had all undergone a standard D2 dissection and then randomized them. Adjuvant chemotherapy alone versus adjuvant chemo plus radiation.
A direct comparison in the D2 setting.
Right. And overall, no significant difference in disease-free survival between the two arms.
No difference again. So, seems like a pattern emerging for D2 resected patients.
It does. However, there was little wrinkle in ARTIST on subgroup analysis.
Ah, the subgroups. Always interesting.
Yeah, there was a signal, not definitively proven, but a suggestion that patients with node-positive disease, or maybe those with intestinal-type histology, might have gotten a disease-free survival benefit from adding radiation.
Node positive or intestinal type. So maybe a specific higher risk group within the D2 population.
That's the thinking. It's a nuance we're still kind of pondering, and it actually led to a follow-up trial, ARTIST-2, looking specifically at that node-positive D2 group. But for the overall population, no clear benefit.
Okay. So let's bring it all together then.
Yeah.
For us today, seeing a patient with gastric cancer post-op, what's the bottom line on adjuvant radiation?
The takeaway is really clear now. In the modern era, with good D2 dissections and effective perioperative chemo like FLOT, routine adjuvant radiation is not the standard of care.
Not the standard. Its role is much more selective.
Much more selective. You reserve it for high-risk situations, like we talked about in R1 resection, positive margins. Or a grossly inadequate lymph node dissection, like in our 0116 discussion.
Right, the cleanup scenarios.
Exactly. But for that R0D2 resected patient who likely got perioperative chemo, adjuvant chemotherapy alone is the established standard. It's a big paradigm shift. We're much more judicious now.
Okay, that's a very clear message. Now, shifting gears a bit. Beyond chemo and radiation, we have targeted therapies. This is where things get really personalized.
Yeah, this is a huge area in GI oncology now. And the trial that really cemented mandatory HER2 testing for metastatic gastric cancer was the TOGA trial.
TOGA, published in The Lancet, I think around 2010.
That's the one. It randomized patients with HER2 positive advanced gastric or GEJ cancer. Chemo alone versus chemo plus trastuzumab.
Trastuzumab, the anti-HER2 antibody.
Right, and adding trastuzumab gave a modest but statistically significant improvement in median overall survival. Went from about 11 months to almost 14 months.
Okay, a few months, but significant in the metastatic setting.
Absolutely. And interestingly, that benefit was most pronounced in patients with high levels of HER2 expression. So the more target, the better the effect, which makes sense.
So the clinical pearl is, any patient with advanced or metastatic HER2-positive gastric or GEJ cancer gets chemo plus trastuzumab, standard of care.
That's it. Fluoropyrimidine, platinum, plus trastuzumab. Critical thing to remember.
You mentioned HER2 and beyond earlier. What's the beyond that residents really need to know about right now? Because that landscape is changing fast.
Great question. The immediate beyond that's standard practice now is immunotherapy. PD-1, PD-L1 inhibitors.
Like pembrolizumab?
Exactly. Pembrolizumab has made huge inroads. Keynote trials like Keynote-061, Keynote-059 showed activity. But the real game changer, maybe, was Keynote-811.
What did that show?
It combined pembro with chemo and trastuzumab in the first-line setting for HER2-positive metastatic disease. Showed really impressive improvements in response rates, PFS.
So triple therapy for some patients, chemo, HER2 target, and immunotherapy.
Potentially, yes. And the key biomarker there is usually PD-L1 expression, often using that combined positive score, or CPS. Higher CPS often means more benefit, especially from single-agent immunotherapy.
Okay, so HER2, PD-L1, any other major actionable biomarkers right now?
Definitely MSI high or DMMR status, microsatellite instability high, or deficient mismatch repair.
Ah, the mismatch repair status. Crucial across many tumor types now.
Absolutely. These tumors may be a smaller subset, but they can be incredibly sensitive to immunotherapy like pembro, regardless of PD-L1 status. So you have to test for MSI or MMR in all metastatic gastric cancers.
Got it. HER2, PD-L1, MSIMFIM. What's on the horizon? Things in trials?
Well, Claudin 18.2 is a big one. It's a tight junction protein. Zolbetuximab is an antibody targeting it, and trials like Spotlight and Glow looked promising, combining it with chemo for Claudin 18.2 positive, HER negative metastatic disease.
Claudin 18.2, okay.
Also, things like FGFR2b amplifications are being targeted. And lots of work on antibody-drug conjugates, ADCs, delivering chemo right to the tumor cell. The field is just exploding with new targets and drugs. Comprehensive molecular profiling is becoming essential.
It really is a different world than even 5-10 years ago. Okay, let's pivot to planning. Let's synthesize this and plan a case.
Sounds good.
All right, imagine this scenario. A patient had an upfront subtotal gastrectomy, proximal gastric cancer, but the path report comes back.
Yeah.
Only 10 lymph nodes examined.
Oof. 10 nodes, that's inadequate. You want ideally 25 or more for good staging.
Exactly. And 2 of those 10 nodes are positive, so inadequate dissection, node-positive disease. What's the call?
This is your classic indication for adjuvant chemoradiation. This goes right back to the intergroup 0116 data, high risk for local regional recurrence because of that inadequate nodal dissection. Radiation has a clear role here.
Okay, so we decide on adjuvant chemo-RT. Let's simulate them. Supine, arms up.
Yep, supine arms up, maybe on an arm shuttle or vac lock. Get IV contrast on board.
And the NPO recommendation.
Oh, absolutely critical. NPO, nothing by mouth, for maybe 2 to 4 hours before SIM and before each treatment. Keeps the stomach empty, reduces motion, huge help for consistency.
Well, probably manage respiratory motion too, like a 4DCT.
Definitely.
Yeah.
Especially for proximal tumors near the diaphragm. 4DCT or gating is pretty standard to account for breathing motion.
Dose, standard 45 gray.
45 gray and 25 fractions is the standard adjuvant dose here based on 0116. But if there was a positive margin, an R1 resection,
Then you boost.
then you consider a boost, yeah. Maybe up to 50.4 gray for microscopic positive margins, maybe even higher for gross residual disease, but that's less common post-surgery.
Right. Now the tricky part, contouring, target delineation, it can seem complex.
It can look daunting, but you break it down. You need to cover the tumor bed, where the cancer was, and the at-risk nodal basins.
Okay, tumor bed, CTV, what goes in there?
For a subtotal gastrectomy like this, you contour the gastric remnant. Give it a reasonable margin, maybe 3 centimeters. Critically, you include the surgical anastomosis, the gastrojejunostomy, high-risk spot.
Don't forget the clips.
Never forget the surgical clips. They mark the spot. And since this was a proximal cancer,
Need to go up into the esophagus?
yep, include a 3 to 5 centimeter margin up into the distal esophagus. Accounts for potential upward spread.
Okay. Now, the nodal CTV. For proximal gastric, it's pretty extensive, right?
It is. You need to cover several stations based on guidelines like the RTOG Atlas. Perigastric nodes, definitely. Celiac axis nodes, super important. Splenic hilum, pancreaticoduodenal, porta hepatis.
And the periortics.
And the periortic nodes, yeah. Usually down to L2 or L3 level. It's a big field covering those main drainage pathways.
That's a lot to remember. Is there an easier way?
There is. A little mnemonic I like for the core upper GI nodal basins, like CTTTS.
CTTTS. Okay, what's that stand for?
Celiac, porta hepatis, pancreaticoduodenal, perigastric, and splenic hilum. CTTTS gets you most of the way there for gastric, even pancreas sometimes.
CTTTS, celiac, porta hepatis, pancreaticoduodenal, perigastric, splenic hilum. Got it. That's helpful. And then the PTV margin.
PTV is usually a 0.5 to 1 centimeter expansion on that combined CTV.
Yeah.
It accounts for setup, motion, maybe a bit more generous inferiorly if you're not using advanced motion management.
Technique-wise, IMRT preferred.
Oh, definitely. Intensity modulated radiation therapy, IMRT, is generally preferred for these complex gastric fields. It's like that drip irrigation analogy versus the garden hose.
Right. 3D conformal RT is the garden hose, sprays everywhere.
Exactly. IMRT lets you sculpt the dose much better. You hit the target, but you can really carve the dose away from critical organs.
Like the kidneys.
Especially the kidneys, particularly the left kidney, which sits right there. IMRT can significantly reduce the dose to the kidney, often getting the median dose below 10 gray, compared to maybe 20 grays or more with 3D. Big difference for reducing long-term toxicity. Also helps with liver, small bowel.
Makes sense. Precision matters with these large fields. Okay, ready for the board blitz?
Let's do it. Test our knowledge.
All right, case 1. 64-year-old man, upfront total gastrectomy, D2 dissection, pathology, T3N1, intestinal type, R0 resection, 2 out of 25 nodes positive, recovers well. What's the most appropriate adjuvant therapy? A, observation, because it was a D2. B, adjuvant chemo with fluoropyrimidine and oxaliplatin. C, adjuvant chemo RT to 45 gray with capecitabine. D, adjuvant RT alone to 50.4 gray. What do you think?
Okay, D2 dissection, 25 nodes, R0. Node positive, yes, but adequate surgery. Based on artists and critics. Adjuvant chemo seems right. Radiation isn't standard here.
You got it. The answer is B, adjuvant chemotherapy. With an adequate D2 dissection, the standard is chemo, like K-Box or Folfox. Routine adjuvant RT doesn't add survival benefit in this scenario based on those key trials.
Makes sense. Next case.
Case 2, Thinking back to Intergroup 0116, the McDonald trial, based on the updated results, which subset of patients was unlikely to benefit from adjuvant chemo RTA male? B, node positive. C, intestinal histology. D, diffuse histology.
Okay, 0116.
Yeah.
Who didn't benefit? I remember there was a histology distinction. Diffuse type tends to spread differently, more peritoneally.
That's the key. The answer is D, diffuse histology. The long-term analysis by Smalley showed that while most groups benefited, the benefit wasn't seen in the diffuse subtype, likely because their pattern of failure is more distant peritoneal, which local RT doesn't address as well. High yield point.
Got it. Diffuse histology exception for 0116 benefit. Okay, last one.
Case 3. Comparing IMRT versus 3D conformal RT for postoperative radiation for gastric body adenocarcinoma. Which organ is likely to be best spared with IMRTA liver parenchyma? B, small bowel. C, kidneys. D, spinal cord.
We just talked about this. That C-shaped field often hits the left kidney hard with 3D. IMRT is much better at carving dose away from the kidneys.
Exactly. The answer is C, kidneys. Dosimetric studies show IMRT can cut the median kidney dose significantly, often by more than half compared to 3D, reducing the risk of renal toxicity. While it helps other organs too, the kidney sparing is particularly notable.
We've certainly covered a lot. It's amazing how much the standards for gastric cancer have evolved, moving from just surgery to this complex multimodality care guided by biomarkers.
It really is fascinating, that interplay between better surgery, better chemo, targeted therapies, immunotherapy, and more precise radiation. It keeps redefining optimal care. The debate on adjuvant RT, while mostly settled for the well-resected D2 patient, still has nuances for high-risk cases.
And the future directions are exciting too. Neoadjuvant approaches are being explored more, trying to shrink tumors before surgery. Radiation for oligometastatic disease using SBRT, perhaps.
Plus liquid biopsies, adaptive radiotherapy. The precision is just going to keep increasing. It's a great time to be in the field, but definitely requires staying up to date.
Absolutely. So, to quickly recap the key clinical pearls for today, adjuvant radiation in gastric cancer. Very limited role now, mainly for inadequate surgery like less than D2 or positive margins.
For well-resected D2 patients, especially after perioperative chemo, adjuvant chemotherapy alone is the standard.
For metastatic disease, biomarker testing is mandatory. HER2, MSIM, PD-L1. Drives therapy with trastuzumab, immunotherapy, and newer agents.
And when you do plan postoperative radiation, be comprehensive. Cover that tumor bed and those nodal basins, remember CPPS, and use techniques like IMRT to spare normal tissues, especially the kidneys, and manage that motion.
We've covered the core principles now for gastric cancer. Surgery, systemic therapy, radiation. It's been a pretty dense session.
It has, but hopefully useful. Next time, we're starting a new multi-part series on another tough one, pancreatic cancer. We'll kick off with part 1, focusing on the adjuvant setting and that ongoing debate about radiation's role there.
Definitely another complex area. And to keep sharp, remember to complete practice oral boards at radoncsmartlearn.com.
And subscribe to Radonc Smart Review for our next session. Thanks for tuning in.